Welcome to the August 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the August issues of the journal, as well as commentaries by Dr. Robert J. Barth on the article entitled Risk Factors for Prolonged Opioid Use Following Spine Surgery and the Association with Surgical Intensity Among Opioid-Naive Patients, and Dr. Ronald E. Delanois on the article entitled Periarticular Liposomal Bupivacaine Injection versus Intra-Articular Bupivacaine Infusion Catheter for Analgesia after total knee arthroplasty, a double-blinded, randomized controlled trial. Be sure to check out this month's Current Concepts Review article, Ankle Arthroscopy, an update by Dr. Jordi Vega and colleagues. Arthroscopic technique is described. For anterior ankle arthroscopy, one technique that has gained favor involves insertion of the arthroscope with no distraction of the ankle and with the ankle in dorsiflexion to prevent damage to the anterior structures. Subsequent distraction can assist with visualization of the middle and posterior portions of the ankle joint. Hindfoot endoscopy is recommended for posterior ankle abnormalities. Indications for ankle arthroscopy and related treatment strategies are also discussed. With respect to ankle instability, the understanding of ligamentous pathology is evolving, and newer diagnoses, including microinstability and rotational instability, are emerging. In this issue, JBJS.org presents a new image quiz, a 65-year-old man with worsening calf pain. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Risk Factors for Prolonged Opioid Use Following Spine Surgery and the Association with Surgical Intensity Among Opioid-Naive Patients by Dr. Andrew J. Schoenfeld and Associates. Investigation performed at the Center for Surgery and Public Health, Brigham and Women's Hospital, and Harvard Medical School, Boston, Massachusetts. There is a growing concern that the use of prescription opioids following surgical interventions, including spine surgery, may predispose patients to chronic opioid use and abuse. The authors sought to estimate the proportion of patients using opioids up to 1 year after discharge following common spinal surgery procedures and to identify factors associated with sustained opioid use. This study utilized 2006 to 2014 data from TRICARE insurance claims obtained from the Military Health System Data Repository. Adults who underwent one of 4 common spinal surgical procedures, discectomy, decompression, lumbar posterolateral arthrodesis, or lumbar interbody arthrodesis, were identified. Patients with a history of opioid use in the 6-month preceding surgery were excluded. Posterolateral arthrodesis and interbody arthrodesis were considered procedures of high intensity and discectomy and decompression low intensity. Covariates included demographic factors, preoperative diagnoses, comorbidities, postoperative complications, and mental health disorders. Risk-adjusted Cox proportional hazard models were used to evaluate the time to opioid discontinuation. This study included 9,991 patients. 84% filled at least one opioid prescription on discharge. At 30 days following discharge, 8% continued opioid use. At 3 months, 1% continued use, and at 6 months, 0.1%. In the adjusted analysis, the low-intensity surgical procedures were associated with a higher likelihood of discontinuing opioid use. Depression was significantly associated with a decreased likelihood of discontinuing opioid use. Conclusions. By 6 months following discharge, nearly all patients had discontinued opioid use after spine surgery. As only 0.1% of the patients continued opioid use at 6 months following surgery, these results indicate that spine surgery among opioid-naive patients is not a major driver of long-term prescription opioid use. Socioeconomic status and pre-existing mental health disorders may be factors associated with sustained opioid use following spine surgery. Next, you'll hear a commentary by Dr. Robert J. Barth on the article entitled Risk Factors for Prolonged Opioid Use Following Spine Surgery and the Association with Surgical Intensity Among Opioid-Naive Patients.
This is Dr. Robert J. Barth providing commentary for the August 2017 JBJS podcast. I will be providing commentary on the article entitled Risk Factors for Prolonged Opioid Use Following Spine Surgery and the Association with Surgical Intensity Among Opioid-Naive Patients. The title of my commentary is In spite of limited generalizability, new findings reinforce the lesson that long-term opioid use is not attributable to surgical pain. Schoenfeld et al. Have provided good news. Prolonged opioid use following spine surgery was extremely rare in their large sample of opioid-naive patients from a national database. This is good news because of the abundance of harmful effects that have been established for opioids. The resulting article emphasizes, quote, "The outcomes documented here directly contravene the narrative that patients who undergo spine surgery, once started on prescription opioids following surgery, are at a high risk of sustained opioid use." Close quote. Unfortunately, the mechanism by which this research contravened that narrative involved exclusion criteria that compromised the relevance of the findings for the majority of surgical patients. For example, the findings cannot be confidently generalized to any of the following groups because they were all excluded from the project. Patients who are eligible for Medicare or Medicaid, which is approximately 34% of the U.S. population. Those with a history of cancer in the previous year, which is approximately 5% of the population. Those with a history of trauma in the previous year, which is approximately 10% of the population. And those with a history of opioid use in the 6 months prior to surgery. After the sample had been reduced by the above exclusions, this final exclusion eliminated 63% of the remaining cases. Consequently, it appears as if this sample was representative of roughly 19% of the spine surgery candidates at best. This reduced representativeness is noteworthy beyond the numbers because several of the exclusion criteria have unique relevance to the study's focus on opioid use. The importance of excluding preoperative opioid users is obvious, but it is worth noting that such preoperative use has indeed been found to predict elevated postoperative use. By excluding those who were eligible for Medicaid, the researchers eliminated a risk factor for higher rates of opioid prescriptions and greater doses per prescription. By excluding those with a history of opioid use, those who are eligible for Medicaid, and those who had a history of trauma, the researchers excluded 3 correlates of mental illness, including substance abuse. Mental illness is, itself, a predictor of future opioid use. Consequently, the exclusion criteria reduced the prominence within the sample of an additional risk factor for opioid use, mental illness. Even so, these new findings still lend support to previous findings of mental illness predicting long-term opioid use. While this exclusion of risk factors associated with opioid use compromises the generalizability of the findings, it also allows the findings to reinforce a generalizable lesson. Specifically, the low rate of long-term opioid use that resulted from such exclusions essentially replicates the findings of prior research that persistent postoperative opioid use is not due to surgical pain, but is instead due to addressable patient-level predictors. The new findings indicate that any patient who is still requesting opioids as of 1 month after spine surgery is clearly an outlier, at least for cases that are free from relevant, objectively verifiable complications, and is consequently in need of evaluation for addressable patient-level predictors, and in need of health care that addresses the predictors that are found to be relevant for that patient. The findings are also supportive of guidelines, they call for surgical discharge prescriptions of opioids to be limited to equal to or less than 2 weeks. It should also be noted that this study's exclusion criteria appear to have produced another unusual result in conjunction with the unusually low rate of prolonged opioid use. Specifically, the researchers identified low rates of mental health disorders in their sample. This is consistent with the low rate of long-term opioid use because mental illness is correlated with opioid use. Because several of the exclusion criteria are associated with elevated rates of mental illness, such exclusion appears to account for the low rates of mental health disorders. Further, the researchers only analyzed for an extremely limited set of mental health disorders and failed to analyze for the types of mental illness that dominate chronic pain presentations. For example, personality disorders and the historical but scientifically validated concept of somatoform disorders. Consequently, readers are warned that the low rates of mental health disorders that are reported for this sample are not generalizable to the entire population of spine surgery candidates, and that previous research has revealed an elevated rate of mental illness among spine surgery candidates. With all of the above in mind, the lesson is that while surgery is statistically a risk factor for long-term opioid use, that risk is largely attributable to confounding factors, such as preoperative opioid use, a history of trauma, and Medicaid eligibility, all of which are correlates of mental illness, which is itself a risk factor for opioid use. Findings from this study and others have highlighted additional risk factors for prolonged postoperative opioid use, which include relatively low socioeconomic status, as noted in the current study, tobacco use, preoperative pain, abnormal body mass index, high or low, middle age, highest for those aged 50 to 59 years, and benzodiazepine use.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Clinical and Radiographic Outcomes of the Ream-and-Run Procedure for Primary Glenohumeral Arthritis by Dr. Jeremy S. Somerson and Associates. Investigation performed at the Department of Orthopedics and Sports Medicine, University of Washington, Seattle, Washington. The Ream-and-Run procedure can provide improvement in shoulder function and comfort for selected patients with primary glenohumeral arthritis who wish to avoid a prosthetic glenoid component. The purpose of this study was to evaluate factors associated with medialization of the humeral head after this procedure, as well as the relationship of medialization to the clinical outcome. The authors collected patient, shoulder, and procedure characteristics along with simple shoulder test SST scores before surgery and at the time of follow-up. Medialization was determined by comparing the position of the humeral head prosthesis in relation to the scapula on postoperative baseline radiographs made within 6 weeks after surgery, with that on comparable follow-up radiographs made 18 months or more after surgery. 2-year clinical outcomes were available for 101 patients. 95% were male. Comparable radiographs at postoperative baseline and follow-up evaluations were available for 50 shoulders. For all patients, the mean SST score and standard deviation increased from 4.9 plus or minus 2.8 preoperatively to 10.3 plus or minus 2.4 at the latest follow-up. Significant clinical improvement was observed for glenoid types A2 and B2. Shoulders with a type A2 glenoid morphology, with larger preoperative scapular body glenoid angles and with lower preoperative SST scores, were associated with the greatest clinical improvement. Clinical outcome was not significantly associated with the amount of medialization. Conclusions. The Ream-and-Run procedure can be an effective treatment for advanced primary glenohumeral osteoarthritis in active patients. Further study will be necessary to determine whether medialization affects the clinical outcome with follow-up of greater than 2 years. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Periarticular Liposomal Bupivacaine Injection versus Intra-Articular Bupivacaine Infusion Catheter for Analgesia after Total Knee Arthroplasty, a double-blinded, randomized controlled trial by Dr. Eric B. Smith and Associates. Investigation performed at Riddle Memorial Hospital, Media, Pennsylvania, Bryn Mawr Hospital, Bryn Mawr, Pennsylvania, and the Rothman Institute at Thomas Jefferson University, Philadelphia, Pennsylvania. Intra-articular bupivacaine hydrochloride (HCI) infusion catheters and periarticular injections of liposomal bupivacaine are often used as postoperative local anesthetics. The purpose of this study was to compare the efficacies of these local anesthetics following total knee arthroplasty. This study was a superiority trial with a randomized controlled double-blinded design. Patients were randomly assigned to either delivery of bupivacaine HCI by the on-cue pain relief system pump or by an injection of Exparel liposomal bupivacaine. The primary outcome of this study was cumulative narcotic consumption on postoperative days 0 through 3. Narcotic consumption data were collected retrospectively from in-hospital records while patients were in the hospital. Following discharge, narcotic consumption data were gathered from patient surveys, as were secondary outcomes measures. The authors did not identify greater narcotic use in the on-cue group compared with the Exparel group. The mean difference between the groups was 0.5 morphine equivalent, with the on-cue group consuming an average 10.4 morphine equivalents compared with 10.9 in the Exparel group. There were no significant differences between groups with regard to any of the secondary measures of pain, with the exception of pain while walking and pain with physical therapy, both of which showed an approximately 1-point difference in favor of the on-cue group on a visual analog scale, VAS. There were also no differences in the postoperative side effects, including nausea, constipation, or vomiting, or in the rates of study-related complications, patient satisfaction, or length of hospital stay. Conclusions. Exparel did not have superior efficacy compared with the on-cue pain relief system, as reflected by narcotic consumption, the author's primary outcome. There were small significant differences in favor of the on-cue group in 2 secondary measures of pain during activity, but these approximately 1-point VAS differences are unlikely to be clinically relevant. The choice of a local anesthetic modality should be based on a combination of safety, convenience, and cost considerations. Next, you'll hear a commentary by Dr. Ronald E. Delanois on the article entitled Periarticular Liposomal Bupivacaine Injection versus Intra-Articular Bupivacaine Infusion Catheter for Analgesia after Total Knee Arthroplasty, a double-blinded, randomized controlled trial.
This is Dr. Ronald E. Delanois providing commentary for the August 2017 JBJS podcast. I'll be providing commentary on the article entitled Periarticular Liposomal Bupivacaine Injection versus Intra-Articular Bupivacaine Infusion Catheter for Analgesia after Total Knee Arthroplasty, a double-blinded randomized controlled trial. The title of my commentary is Comparison of liposomal bupivacaine with bupivacaine pain pump in total knee arthroplasty patients. The purpose of this study by Smith et al. Was to compare the efficacies of Exparel, a single-dose periarticular injection of liposomal bupivacaine, the on-cue pain relief system, and intra-articular bupivacaine hydrochloride infusion pump catheter in patients treated with total knee arthroplasty. Given the implications of pain management and patient satisfaction for provider reimbursements, studies such as the present one offer valuable insight on potential opportunities for arthroplasty surgeons to improve quality of care. Inadequate pain control after total knee arthroplasty has been associated with increased length of stays, delayed rehabilitation, and increased patient morbidity. While opioid-based medications have been a commonly employed solution for this problem, a growing epidemic of opioid abuse and overdose has galvanized efforts from both legislative and medical communities to reduce opioid administration. For these reasons, newer pain control modalities, such as Exparel and ON-Q, which have been claimed to reduce opioid consumption, are being increasingly evaluated. The study differentiates itself from previous reports by being the first to compare the efficacies of Exparel and ON-Q. In this randomized, double-blinded clinical control superiority trial, patients scheduled to undergo TKA were randomly assigned to treatment with either Exparel plus a dummy catheter or ON-Q. The primary study outcome measure was cumulative narcotic consumption on postoperative days 0 through 3. Secondary outcome measures included assessment of pain, side effects, patient satisfaction, length of stay, and catheter-related complications. The authors found no significant difference in cumulative narcotic consumption between the patients who received Exparel and those who received ON-Q. Additionally, no significant difference were observed in any secondary outcome measures, with the exception of clinically unimportant differences in pain with walking and pain with physical therapy as measured by a visual analog scale. This study serves as an important step in continuing efforts toward optimizing the value of care. Prior to the Affordable Care Act of 2010, the emphasis of healthcare was placed on volume. Since then, the overarching goal for both medical and legislative communities has been to achieve high-valued care for patients. Value defined as health outcomes achieved per dollars spent is now the focal point of newer implemented reimbursement models, such as a value-based purchasing program, bundle payment for care improvement initiative, and comprehensive care for joint replacement model. These models reward entities that provide optimal care value to patients through low cost of care or better outcomes. The authors discussed potential cost savings associated with the use of the ON-Q when compared with more expensive Exparel. However, they rightfully suggest that the cost savings be weighed against potential risks associated with indwelling catheter use. While no infections were reported in the ON-Q cohort, the authors mention anecdotal accounts of an increased risk of infections associated with the presence of intra-articular catheters. Interestingly, the current literature reflects a different stance. In a retrospective study of 1,915 consecutive primary total knee patients, Ham et al. Reported no significant difference in the rate of deep space surgical site infection between patients who did and those who did not receive an intra-articular catheter. Notwithstanding, orthopedic surgeons must still consider catheter-specific complications such as leakage and breakage, which may lead to reduced satisfaction or a return to the operating room. A study by Smith et al. Has confounding factors that warrant mentioning. Exparel requires extensive meticulous injection into the periarticular tissues, including infiltration of the posterior aspect of the capsule and the periosteum prior to surgical closure. Lack of infiltration into the posterior aspect of the capsule and the periosteum may have offset the drug's analgesic effect in this cohort. Catheter leakage was reported in approximately 20% of patients in the ON-Q group, suggesting insufficient infiltration of the studied drug. The authors also state that the ON-Q may be a cheaper alternative to Exparel, but do not account for the cost of the Bupivacaine used in the pump. After factoring in the cost for the analgesic, it is entirely possible that the cost of the ON-Q may be similar to that of the Exparel. However, as stated by the authors, these costs are likely vary from institution to institution. Nevertheless, we commend the authors for their work as it continues the discussion on how best to improve the value of care that we deliver to our patients. Larger powered observational studies are needed to assess the cost effectiveness of ON-Q and Exparel. This should be conducted with particular emphasis on factoring in all benefits and expenditures associated with modality-specific complications.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Timing of Postoperative Mechanical Loading Affects Healing Following Anterior Cruciate Ligament Reconstruction. Analysis in a murine model by Dr. Christopher L. Camp and Associates. Investigation performed at the Hospital for Special Surgery, New York, New York. Following anterior cruciate ligament ACL reconstruction, the mechanical loading of the tissues has a significant impact on tendon-to-bone healing. The purpose of this study was to determine the effect of the timing of the initiation of mechanical loading on healing of a tendon graft in a bone tunnel. ACL reconstruction using a flexor tendon autograft was performed in 56 mice, randomized to 4 groups, with differing times to initiation of postoperative mechanical loading. 1. Immediate. 2. 5 days. 3. 10 days. Or 4. 21 days following surgery. An external fixator was placed across the knee at the time of surgery and removed when mechanical loading was scheduled to commence. Following removal of the external fixator, animals were permitted free, unrestricted cage activity. All mice were killed on postoperative day 28, and tendon-to-bone healing was assessed by biomechanical testing, microcomputed tomography, micro-CT, and histological analysis. The mean failure force and standard deviation of the reconstructed ACL at the time of sacrifice was highest for Group 2 compared with Groups 1, 3, and 4. Micro-CT bone volume fraction was the greatest for Group 2 in the femoral tunnel, tibial tunnel, and both bones. Similarly, histological analysis demonstrated a narrower scar tissue interface and increased direct contact at the tendon-bone interface for Group 2. Conclusions. Following ACL reconstruction, a defined period of immobilization without weight-bearing appears to improve biomechanical strength of the healing tendon-bone interface, while prolonged periods without mechanical load and motion decrease the ultimate load to failure in this murine model. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.